Welcome, everyone, to Docs Toc, episode 40. Today we have Dr. Keith Ellis. Dr. Ellis is Associate Professor, Virginia Commonwealth University. He is a medicinal chemist. Medicinal chemist is someone who uses their expertise in chemistry to identify new medications. And Dr. Ellis is here today to talk about long COVID. What is it? What is the mechanism of long COVID? Who's at risk? How is it treated? Symptoms. We go into a deep dive into long COVID. We also talk about Dr. Ellis created a supplement to help potentially treat patients with this condition. Please note that this supplement is not approved by the FDA. Our podcast is not endorsing Dr. Ellis. We have no financial relationship with Dr. Ellis. We offer this information as educational, informational content. As always, if you like our videos, please like, subscribe, and share with others. We're trying to reach as many people as possible. And also, please consider signing the petition that I created a few weeks ago. This is a petition to encourage Congress to pass the Protecting Rural Health Telehealth Access Act. So at the end of the year, telehealth home access is going to end for Medicare participants unless Congress acts to fund this for 2025 and beyond. So there's a petition link in the show notes. Without further ado, here's our interview with Dr. Keith Ellis. Welcome, Dr. Ellis, to the show, and we're so glad you're here and really curious to hear about if you could tell us what is long COVID and how did you become interested in this problem?
Yeah, thanks guys thanks for having me. And obviously the world changed, back when COVID struck in 2020. And one of the other things that people talk about and are experiencing that doesn't get quite as much maybe press as acute COVID infections is the condition that people are increasingly calling long COVID, right? And long COVID is this kind of distinct condition that people get after they've had COVID, and not everybody gets it. But typically, the normal progression is somebody will have an acute COVID infection, and they get most of the way better. Maybe they get 80% better, but still 3 to 6 months after having their acute COVID infection, they'll still have some symptoms. They never really got 100% better, and then they start developing some new symptoms. And the new symptoms that are what's typically associated with long COVID, there's really a large number of them. And it seems like most people experience long COVID in some ways that are similar to other people, but in some ways that are different. So it's kind of a heterogeneous disease in that it's got a lot of different symptoms, and not everyone experiences it exactly the same.
Sounds like one of our clinics that we have, and we say diseases don't read the textbooks, and this sounds like a good example.
So I think at this point, most people have arrived thinking of it kind of as a syndrome because it has some, diagnostic criteria in terms of a timeline from a COVID infection. You have to be 3 to 6 months out past an acute COVID infection. And then it has what I come to think of as kind of core symptoms, and then this constellation of symptoms where people get some but not all of them. So the core constellation of the core symptoms for long COVID tend to be things like your fatigue, like the brain fog, that lack of mental clarity that really impacts people being able to function in daily life. And there's usually some sort of cardiac involvement, some shortness of breath, maybe with physical activity, some issues with um, maintenance of heart rate, right, and having kind of a lack of control there. And those are kind of the core symptoms that most people tend to experience. And then from there, there's this whole constellation of symptoms that people will see, and some people will get some of them, some people will get others. So there's additional cardiac symptoms that go along with long COVID. Things like what people call POTS, or postural orthostatic tachycardia syndrome, where when they stand up, they're not able to really maintain their heart rate, and they get lightheaded, and everything that comes with that, and that increase in heart rate, that tachycardia, um, that comes with standing, is kind of independent of any kind of low blood pressure. right? People will suffer from dysautonomia or dysregulation of the autonomic nervous system that controls your heart rate and your breathing and all those other really important things. People will get muscle pain or joint pain and stiffness, neuropathy. There's a whole constellation of CNS kind of neurological symptoms that go along with the brain fog. There can be headaches and really severe brain fog and people not being able to function, mainly thought, what's thought by caused by neuroinflammation. There can be GI tract involvement. People get gut dysbiosis and leaky gut that presents in some people. And then there's usually some kind of immune system component that can vary in severity, all the way from things that are more like an autoimmune response, all the way through MCAS and really severe mast cell activation. So there's this whole constellation of symptoms where people kind of have these core ones and they don't feel good. They lose a lot of function as they get sick with long COVID. A lot of people have trouble with daily activity. They're fatigued a lot. They're in bed a lot. And then there's other symptoms that present with it that make it better or worse for some people.
No, so is there any gender predominant than
I haven't seen any like really well done clinical studies, but when you talk to the patient population, the anecdotal kind of demographics seem to be it hits people that are a little older. So it hits maybe 30 to 65 is kind of the age range. And it does seem to hit more predominantly hit women. And it's almost like what I've seen is more like a 70-30 split where the majority of long COVID people that I talk to do tend to be women, and there is for some reason it does tend to hit them.
what about the conditioning after the COVID? We get um, the viral illnesses, and of course, you get fatigue after that. It seems like this chronic fatigue with deconditioning and also a little bit of depression goes with that too. Is that right?
Yeah, and I didn't mention that depression and anxiety are two of the neurological symptoms that will often present with long COVID, and there can be a couple reasons for that. One is the limitation in function causing people to be depressed. Right, they can't be active in their life, so that leads to some depression. But also in terms of real a chemical effect, there seems to be some involvement with platelet hyperactivation as an underlying mechanism that for what causes long COVID. And part of that is you get serotonin dumping out of the platelets and serotonin depletion, which then can go on to cause some of that anxiety and depression like symptoms as well.
Everything's related to the platelet. It's interesting. How did you get interested in this, Dr. Ellis? It seems so unique, a bit unusual, actually, to see someone with your title doing long COVID.
Yeah, so I'm in kind of academic. I'm a professor. I'm a scientist. I'm a medicinal chemist, and my kind of job in the whole ecosystem of science is I do what I call early stage lead discovery. So that's looking at a disease state and maybe trying to find a new molecular target to develop a new drug. And that's kind of what I'm interested in. I'm kind of a big mechanisms of action guy. I like new mechanisms of action. I like new targets, and then developing new hits and then leads to make new drugs to try to help treat diseases. So with long COVID in early 2023, I decided, well, COVID's been around long enough. Long COVID was starting to really present as a more severe problem for a lot of people. I went in to kind of start an academic project the way I normally would, right? And I went into the research literature, and when I go in and look at a disease state like this and I start looking at molecular targets, I'm really looking at molecular level physiology in the body. So I want to really drill down into the details of the mechanisms at kind of treating them with a chemical point of view, but in the biological system, right? And really understanding the biological mechanisms to start selecting targets and doing drug discovery. And that's what I typically do in the way I do any project. And I went into the long COVID literature, and looking at things, and I took a while kind of surveying literature, and I came away with a different result than I expected. I was a little surprised, a little shocked by what kind of was and wasn't in the scientific literature, because um, there's a lot of money going into long COVID research. There's a lot of papers being published. There's a whole ton of work being done, and for the most part, it's all extremely excellent work. But with the volume of work being done, I expected the field to be much more ready to start really doing traditional drug discovery. And what I found out when I went into the literature was there was a lot of work going on, a lot of work on the symptoms, a lot of work trying tying mechanisms to symptoms, but not as much work as I would have liked to have seen on the underlying kind of pathophysiology mechanisms of long COVID. And so I did all this, and I got to that result, and I took a step back and I said, well, the literature is what it is right now, right? Like you have to, science takes time. So as much as we all hate that, right? Sometimes you have to wait for things to develop in order to move forward and do certain things. So the one place where I did find really good pathophysiology data, and some scientists doing some really nice work, is on something that's called the Microclots Hypothesis as kind of one of the causative mechanisms behind long COVID. And I dove in and started doing a lot of research on that and looking at the direction that was going. And there's some pretty good information in the literature that microclots really are one of the causative mechanisms for long COVID. And because of that, they offer a potential therapeutic route. And then also, there's some nice work in the literature showing that they could be causing a lot of the symptoms that people are experiencing. So if you can alleviate microclots, you can actually start alleviating symptoms from COVID and actually treating the underlying disease state.
Did you have any personal interactions with COVID, or did you get it? Did any of your family or friends have it, or did they develop long COVID?
Like most people, I got my typical COVID infection. My whole family caught it at one point. Fortunately, I didn't get long COVID, but I did start running across. I had a couple friends that got long COVID, and I had one of them come to me, and they were frustrated because they were having trouble finding solutions, and they'd gone to multiple doctors, and were kind of getting to the end of their rope in terms of looking for help. And they came and said, what is going on here that there's not more help for this. And that is kind of one of the things that made me dig a little harder and look a little deeper, because from what my friend told me, there just were not really a whole lot of good options for anybody with long COVID. And the unfortunate part is the numbers for long COVID are getting kind of scary. There was a nice Nature Medicine paper that showed, as of the end of 2023, worldwide, there had been over 400 million cases of long COVID. That's a lot of cases of long COVID, a lot of cases of a disease that we don't really have a lot of good treatments or support for people that are suffering from it. And the other scary number is every time you contract acute COVID, you basically have a 1 in 10 chance of getting long COVID. That's what the numbers seem to be bearing out. So in the risk of getting long COVID doesn't change. It's like every new infection, it's kind of a 1 in 10 roll of the dice. And, I know some of my favorite the holidays, I was not able to see them because they had gotten COVID right before the holidays. Like, okay, we're staying away from you. It's a scary prospect when something as debilitating as long COVID has that high of a prevalence rate, when you don't really understand how to protect yourself from it, how we don't really understand predictively, right, who's going to get it and who's not, and there's not a whole lot to help people once they do get it.
About demographic, have you seen a certain region of the world is more prominent or more prevalent than other area?
I haven't seen any trend in terms of different countries. The 400 million number, it was a worldwide number in terms of total number of cases. I don't remember what the breakdown was like country by country. But I don't think it's not like Europe or some segment of Asia where the US has like this massive spike higher prevalence. It seems to be an across the board, kind of like COVID is now, right? Because at first, as we went through the COVID pandemic, there were some countries that did get hit harder. But as we've gotten out into the variants now longer away from 2020, it seems to hit more evenly and more distributively because the virus is evolving.
Is there anything that patient can do if they got COVID to prevent long COVID? Is there anything that a person can, whether nutrition, hydration, or what? Is there anything that can help that doesn't cause it, prolonged disease?
So at this point, I have not seen any real literature, any real research on trying to use preventative measures to try to hold off long COVID. What I have seen is kind of the converse question of which groups seem to have been more at risk, looking at the subpopulations of people that get long COVID, right? So the people that were more seem to be more at risk based on who develops long COVID and who doesn't seem to be people with that already have a pre-existing immune type issue. So people that already have an autoimmune disease are one example of that. Another real interesting subgroup is there's a disproportionate number of people that I talked to with long COVID that before they got COVID were like high performance athletes, right? So they were running a lot, they were marathon runners, they were triathletes. It seems to disproportionately hit that population. And when you take a step back and think about it and look at it, it makes sense because training hard for high endurance athletes kind of pushes the energetic system, it depletes it, and it pushes the immune system, right? To the point and I've talked to some high endurance athlete coaches that have a lot of long COVID patients. And they said it's normal when they're doing a really heavy training block towards the end, people are more susceptible to getting sick, getting a cold, getting a flu. And it seems like that state of stress for the immune system seems to put that population more at risk for getting long COVID. So you can kind of generalize that. If we know it hits people that tend to have autoimmune diseases, athletes that are kind of really pushing themselves and are depleting their energy, pushing their immune system kind of to the limit. So you can start getting some insights that people that do have any kind of immunological issue before they get COVID are kind of more at risk for getting long COVID. That's the only kind of rhyme or reason or rationale I've seen so far for who gets long COVID and who doesn't. There's not clear cut risk factors because it seems to hit people whether they're like right with acute COVID infections. We know you're at higher risk if you are obese or diabetic or have some of those comorbidities that occur with COVID. Long COVID doesn't seem to follow those same trends as the acute COVID infections.
Maybe before we talk about the the microclots and clotting with COVID, could you talk a little bit about what treatments have been looked at? Are there any recommendations for someone with long COVID? And obviously, if you think you may have long COVID, please seek medical advice. But what options are out there right now for patients?
So, obviously, the place for patients to start is with their primary care physician. And what seems to happen with a lot of them is they go to their primary care physician, and it's kind of one of two things. Either the primary care physician gets invested and says, okay, let's figure out what we can do to help you from what's new. And there's a somewhat of a list of those. And if, for instance, if you have a lot of immune response going on, and you think there's MCAS going on. People are repurposing histamines to use to kind of treat MCAS. There's a lot of attempts to use some pharmaceuticals like a single anticoagulant if they think there's clotting issues, or if they think there's circulatory issues. There's a lot of use of antidepressants, right, and anxiety meds to try and treat those symptoms. But a lot of times what's happening is people are presenting with a complex set of symptoms, right? They're presenting with symptoms that cross our normal boundaries between physiological symptoms, right? So there's cardiac involvement, there's circulatory system involvement, there's CNS involvement, there's immune system involvement, there's GI tract involvement, respiratory system involvement. All of a sudden, so what happens a lot of times is patients will go to the doctor. It's not clear cut what's going on. The doctors, the primary cares will often start referring them and send them to a series of specialists, trying to figure out what's going on the way that we normally do for most conditions. And a lot of times the patients seem to be getting on this kind of treadmill of not getting a ton of help. They're using over the counter drug products to treat kind of symptoms in isolation, right? So they might be able to get prescriptions to treat some of the known issues going on, depending on whether it's cardiac, et cetera, or they're getting OTC drugs to help with maybe some of the respiratory issues, congestion, feeling like they're still sick. Like it's kind of almost, I don't want to say scattershot, but everybody is basically repurposing OTC products, prescription products, or supplements that existed pre-COVID, right? A lot of people will take nattokinase to try to reduce spike protein, because one of the causative hypotheses behind long COVID is basically that you have viral reservoirs that are persisting in the body, and that the presence of virus and viral related proteins is what's causing long COVID. So if you can clear those viral proteins with something like nattokinase, people are using that. And there's a whole host of supplements that people are taking for some good and some maybe more unclear mechanistic reasons to try to help support their body to recover naturally from long COVID.
There's no laboratory data that you can do. Like majority of the laboratory data is normal. Is that correct?
Yes, and this is one of the issues, and where I really sympathize with the physicians, because I think the physicians get beat up a lot by the long COVID patients because they're frustrated because they can't get help. But when a patient goes in and the doctor runs all the labs, everything looks normal, right? So just about all the blood chemistry, all the panels that you would normally do as a physician are all coming back normal on this person, yet they're still obviously sick. What can you really do at that point with somebody when you don't really know what's going on because you're not detecting it? And that's why they tend to get moved to going to a lot of different specialists, hoping that you're going to get to a specialist that's able to find something that doesn't show up in the normal.
You mentioned the MCAS. Could you just define that for our audience?
Sure. MCAS is mast cell activation syndrome. So it's a really severe form of mast cell activation, which is part of the immune response. So the body really starts attacking itself through the mast cells. And what the patients that I've talked to tell me about it is it makes them very sensitive to just about anything. If they have the mast cell activation, they have to really cut down on anything that they're going to eat or drink or supplements they're going to take, because anything foreign that comes into the body risks triggering an even worse increase in that immune response and the inflammation and all the effects that go with it. That really is some of the worst symptoms people do experience.
I remember early on in the COVID pandemic, one of my first consults for a hospitalized patient was for a splenic infarct. And that's so clots in the spleen, loss of blood flow in the spleen. And also, I think this patient had portal vein thrombosis, a vein that goes to the liver. And I thought this is strange. And then the infectious diseases consultant said, no, Rob, we see this all the time with COVID. This is something that goes along the diagnosis. So there's something here, with this whole clotting, and you think it's microclots. Could you elucidate on that a little bit?
So let me tell you about the hypothesis, and then I'll tell you some of the data, which is what I find really convincing, because it's good molecular level data. So the thought behind the microclot hypothesis is that viral proteins, and specifically COVID spike protein, when it's circulating around in the circulatory system in the bloodstream, it is binding to proteins that normally form clots. So fibrinogen, right, is the main one. The idea is that spike protein from the virus binds to fibrinogen and actually causes it to shift into an unnatural conformation. And this unnatural conformation of fibrinogen actually polymerizes and conglomerates into larger microclots. Those microclots are it's a completely unnatural conformation, and they're sticky. And so the microclots actually stick to platelets. The platelets then get activated, and with platelet hyperactivation comes a whole cascade of other things that happen, right? Which I'm sure you're going to want to talk about. So you end up with these microclots that are a conglomerate of improperly folded fibrinogen protein that stick to platelets, that stick to red blood cells, that and all kinds of other proteins and molecules in the bloodstream, and that those are downstream what's causing a lot of the symptoms, right? So these improper blood clots, going through your circulatory system, it's causing inflammation in the endothelium of the blood vessels. So that's one sort, the beginning of part of the source of the inflammation in the body, right? You're trapping red blood cells, so you're interfering with oxygen delivery into tissues. That actually causes both fatigue, kind of on a general scale, but also if you think about hypoxia, that's hypoxia and decreasing oxygen delivery to the brain, that can account for some of the brain fog. And then, of course, if you've got these unnatural microclots, they can get autoantibody formation against them, where the immune system is reacting to them as foreign bodies. So it kicks off immune system response in its own way. So it's kind of this unifying hypothesis. And one of the ways you can think about these microclots is they're described in the scientific literature as amyloids of fibrinogen, right, which is the protein that forms clots in our blood. And when we think about amyloids, the first thing that most people are familiar with are amyloids of tau or A beta that are causing Alzheimer's, right? They're kind of the same thing, where they're these unnatural conformation protein complexes that are forming these microclots that then are causing all kinds of havoc, that are actually, you can understand and envision mechanisms where they are crossing the various physiological systems and causing problems beyond just the circulatory system and the cardiac system.
So I can get to the, with acute COVID, maybe even a couple of weeks later after the infection the immune system has taken care of the infection. Maybe there's still some microclots or other, coagulation system activation. But how can this extend out for 3 to 6 months?
And that's one of the things that's really kind of not known, is why is it that time, right? So the thinking is that long COVID is, as I said, long COVID is really caused by viral reservoirs somewhere in the body, right? And there's a lot of work being done to say, okay, well, where are these viral reservoirs existing? Where can we take care of? One of the leading theories is they occur in the GI tract, and that you end up with a viral reservoir basically in the GI tract. It's what causes the gut dysbiosis and the leaky gut. And because you end up with a viral reservoir there, over time, you're getting transmission of virus and viral proteins across the line in the GI tract into the bloodstream. And that's one source. Another source that people are focusing a lot right now um, is in the brain, in the CNS, thinking that viral reservoirs are what's causing a lot of the neuroinflammation that is being studied really, really heavily right now. So at the end of the day, it what I can tell you is the data in the data in the literature shows that if you take spike protein that you make in the lab and you take a blood sample and add it, you get microclot formation. Those microclots aren't detectable in standard clinical chemistry testing, right? But there has been a research laboratory based assay that's been detected for them. It's a fluorescence microscopy assay with a stain, right? And you can detect those microclots. They seem to be caused in a more of a biochemical experiment. They seem to be induced by spike protein, and then those same types of microclots can be visualized in patient samples from long COVID patients. But the microclots aren't there in patient samples from acute COVID. It There is this time parameter and something that goes on in that intervening period where people shift over from not having microclots to having this microclot mechanism go on. And as far as I know from reading the literature, every long COVID patient that's been tested for microclots that's been reported in the literature, they've been able to visualize microclots in those patients.
And for others, the COVID tests on this individual are negative, right? I know I had the COVID 3 times. The first time was terrible. And then initially they say after 6, 7 days, because the one I was trying to donate some plasma, and with the University of Colorado, then this is, well, don't be surprised. Just give it another week. It took me about 28 days to just become negative, which most of the times they say, well, 7 days is good enough. But in the long term, the tests that we have for COVID, they do not detect any COVID particle or any COVID um, test. Is that correct?
I mean, it depends on which testing you're using for acute COVID, right? So whether you're using a PCR based test or whether you're using an antibody based test, right? Because there's a few different technologies out now for the rapid testing and the people um, that are doing clinical testing to say, okay, do I have a COVID infection? There's a couple of different assay types out there for that are kind of point of care testing. Um, and typically people with long COVID will test negative in all of but they will still have these symptoms. And again, it's like they recover most of the way from the acute infection, but then they turn down again and start picking up new symptoms, which is the kind of the it's the as scientists, it's the interesting part. As people experiencing it, it's the really horrible part, right? Because we don't quite know exactly why or how to help.
So you saw all this data, you saw the clinical scenarios, and you decided to to, to take a novel approach. And could you tell us a little bit about what you've or how you got started on this path and with this supplement that you have and what it's intended to do and yeah, I would just like to learn a little more about what you've done.
So in going through the microclot hypothesis, the scientists that have done this, it's Ricia Pretorius in South Africa and Doug Kell in the UK. They've done really nice work. Like with the data they published, it's like, okay, I'm a big believer in the microclot hypothesis, and they actually took it a step farther and they did a small trial with some patients. They took a group of about 90 patients and that all had long COVID. They looked ahead of time. They all had microclots, right? So, and they treated these patients with a therapy called triple anticoagulant therapy. And it's a mixture of, it's really one anticoagulant, it's apixaban, and then it's two platelet activation inhibitors, aspirin, which is Cox 1,2 inhibitor, and then clopidogrel. So they gave them this pharmaceutical cocktail, and depending on how severe the person's long COVID it was, they were on it for either 2 to 4 months or 4 to 6 months. And at the end of the study, they had about an 80% recovery rate from long COVID using triple anticoagulant therapy, which, and again, it's a small study, but that's a pretty good result, right? So, okay, I was like, well, problem solved. Why isn't everybody just getting triple anticoagulant therapy and getting over their long COVID, or the majority of it, right? So turns out there's some issues with triple anticoagulant therapy when you really look at it. So the first one is you're kind of given three quote unquote anticoagulants together. A little bit of a safety issue, right? There's a high risk of a side effect like bleeding, right? So that's issue number one. Issue number two is two of the three are pharmaceutical drugs that you need a prescription for. And kind of understandably, a lot of physicians were reluctant to write the script for triple anticoagulant therapy without more data, without a larger clinical trial. Given the side effect of risk of bleeding, there was some reluctance. So most long COVID patients could not get a prescription for triple anticoagulant therapy. And then kind of the third issue was because there hasn't been a real study on, it's not approved for long COVID, a lot of patients were having issues with insurance not wanting to cover it if they could get a script. So there's a cost issue because these are not cheap drugs. And at this point, the only people that I've been able to talk to that seem to have success getting triple anticoagulant therapy were going to these private long COVID clinics that were popping up. And at those clinics, they do tend to do testing for microclots. They will get you on a protocol for triple anticoagulant therapy, but that's all private pay. They typically don't take insurance. There's long wait lists for those types of clinics. So it's like there was this solution that wasn't quite ideal, that people didn't have access to, wasn't the safest thing in the world, and was expensive. And I said, well, what we really need is like a safer, more available, right, more readily available and cheaper version of triple anticoagulant. And that's kind of where I just did some work and used kind of my unique position as a medicinal chemist to flip the script around and create something that filled that need.
I saw the ingredient list, but how did you decide on those specific ingredients in the supplement?
So basically, so early in my career, my earliest training, I'm a natural products chemist, and early in my career, I used natural products as the starting points for doing drug discovery. So one of the things I said to myself was, well, okay, we have three pharmaceutical drugs. They're just too strong. They're too potent, right? That's why you have that risk of bleed. So I decided to kind of invert or flip what we would normally do. The normal process in drug discovery has been you start with the natural product and then you make the drug, right? You make something much more potent, much more optimized. I decided to basically just flip that, and I reverse engineered the pharmaceutical cocktail into a supplement using the mechanism of action for each drug. So, for instance, apixaban is an anticoagulant. It's a factor 10A inhibitor. That's the mechanism of action. I went and I kind of drilled into the literature to find a natural product that is a factor 10A inhibitor. And it turns out that the curcumin in turmeric is actually a factor 10A inhibitor and was one of the lead molecules used to kind of develop a class of anticoagulants. So I basically did that for each of the three drugs, reverse engineered it through the mechanism of action to a natural ingredient to formulate into a natural supplement that has the same mechanisms of action, but it's a little less potent. It's a lot less potent, actually. So it's safer. It's a supplement, so it's available over the counter. People don't need to go to a physician to get a prescription, and it's fairly inexpensive compared to the pharmaceutical.
Do you administer the supplement along with aspirin?
No, because there's willow bark extract in the supplement, which is also a COX-1/2 inhibitor, which is the same mechanism of action as the aspirin. So um, basically, what I did was I wanted an all-in-one formula where people could just take what's in this product and get the same effect as having triple anticoagulant therapy, because the important thing here is that you get all three mechanisms of action together, right? So I wanted one product that did that. The other option I tell people is that they can get the components themselves if they want to, and just take it on their own, right? If they want to take the turmeric and the aspirin and take danshin, which is the P2Y1, P2Y12 receptor inhibitor, that's the mechanism of action of clopidogrel, right? So they can take those three components together, and it will have the same effect. And actually, as I was manufacturing my product, I had some impatient people in my audience that actually did that, and it worked. And I was like, okay, now I'm feeling really good, because people were getting results with it, taking them separately, and then once they switched over and started taking all three of them together, it seemed to work even.
Could you go through all the stuff that is in the supplement?
So there's turmeric, which it's organic turmeric. There is white willow bark, which is the replacement for the aspirin. There's a natural product called danshin. It's an extract from traditional Chinese medicine. So that's the replacement for clopidogrel. So it's those three components. There is some black pepper extract in there, which is a component that helps with the bioavailability of the turmeric. That's the only reason it's in there, is it helps the turmeric. It's a sacrificial substrate for metabolism, helps the turmeric be metabolized more slowly, so you get better bioavailability. And I actually put some beetroot extract in there. And that was to help people with the fatigue, which is one of the worst symptoms that people have. And it's one of the universal symptoms, right? So beetroot extract has nitrates in it. It actually helps with oxygen delivery to the tissue. And it kind of helps people right away start feeling better and having more energy from getting improved tissue oxygen.
And how many patients did you treat, and what were the conclusion? How did you come to that dosing, and how many patients those trials?
So the dosing is basically I maximized each of the three main components to be able to do a 2-capsule serving. Was really the way that it was designed. I talked to people with long COVID. They're like, please don't give us anything that's more than 2 capsules to take, because they just didn't want anything more. So I said, okay. So in terms of, as I was doing this, I was building a small audience of long COVID people on my own social media. As I went through and did all my research on Microclots Hypothesis and doing the design for the product, I kind of did it all open access. I published it all on Substack, and was making videos about it on TikTok. And so I have a small audience. So far, I would say about 200 or 300 people have tried it. And I have not done any kind of clinical study. I basically am getting feedback from people. I have a lot of people that are telling me it works. The reorder rate is really high. When people are buying it, they are coming back for more, because it is making them feel better. But I'm still in the early stages of really collecting a lot of formal feedback. But I've got reviews and testimonials, and it's one of those. I have enough people telling me that it works that I'm keeping moving forward. If at this point people told me it didn't work, I would just move to something else, right? It wouldn't be worth it to keep going, but it does actually seem to be helping people quite a bit.
And how long should they take it to feel the difference?
It is designed to take it and then eventually be able to stop taking, right? So I kind of base the timeline for how long to take it based on the small clinical study they did. And part of it depends on how severe their long COVID is, right? So if you have more mild long COVID, I tell people maybe 3 or 4 months. If you have more severe long COVID, I tell people you probably are going to want to take it for 6 months. And there are people in my audience that are taking it for that long, and it does seem to be helping.
Do you plan to do any studies? Maybe because there's a medical school attached to your Virginia Commonwealth. Is there not, or at least close by?
there's a medical school and a pharmacy school, and I'm hoping to. Right, I have been searching for, and this is kind of the problem in academia right now. I here at VCU, I haven't been able to find a ton of people focused on long COVID. For instance, I don't have any pharmacist colleagues that are focused specifically on long COVID at this point, because that was kind of my starting point. At this point, I am absolutely willing to study this and do everything we can. The only thing I haven't figured out yet is how to fund the trial and how to fund the study, right? And that's really if I could figure that out, then absolutely I would move forward as fast as humanly possible with trying to do a study.
How about NIH? I mean, you're close to them. Maybe have you tapped to them?
NIH, there's a lot of grant money going into COVID and into long COVID. It seems to still be going a lot into clinical work. It's going a lot into drug repurposing of existing drugs, and it's going into studying more basic science and mechanism of action. I haven't seen anything yet in terms of funding opportunities for actually funding, because at this point, most of the long COVID patients are using supplements in some way, shape, or form to help themselves try to recover. I haven't seen funding mechanisms that from NIH to actually study those at this point, which it would be nice that if that that option were recognized as one that should be studied. I don't know, maybe with future changes that are coming at NIH, that might be an option. And again, I would be happy to do it, but I haven't seen anything for long COVID specifically. And in general, I'm not familiar with a lot of the mechanisms for studying supplements that don't have kind of more of a better track record and haven't been around for a while.
We'll certainly applaud your efforts, and yeah, yeah, and what you said is, I think, is a good point. Is that I don't think there's a company on the planet that would, um, you know, want to get involved with this in its current form. But if they could find something they could patent, then they probably would have something they would be interested in, I suspect.
Well, and we didn't kind of talk about, but one of the reasons I decided to do this very non-traditional path for somebody in my position was it was very clear when I looked at the literature, right? To develop a drug from the very beginning takes like 10 to 15 years, right? That's kind of the drug development timeline. If we're not ready to start that process, it's going to be at least that long till we have real new custom developed pharmaceutical drugs that are really targeted to long COVID. What are people supposed to do until then? Right. And that's actually really why I created my product, because it was very clear pharmaceutical industry isn't going to move till there's more data in the literature and they can figure out how they're going to make money. Right. And to be fair to pharmaceutical industry, that's what they do, right? They aren't they aren't evil. They aren't, they're a business, but they're not a charity. They're not going to do it if they can't get a return on the investment, which I respect, right? So in the meantime, where are people left to get help? If people don't do some things like this and come up with some things in the meantime, um, I fear that people with long COVID are kind of just going to be left to suffer, because um, there there is so much of a difficulty in diagnosing it, and there's not a lot of tools for the physicians to help. So I'm just trying to give people some options to help themselves recover if that's something they think they want to try.
It's very unfortunate in this culture. We have such thing between modern and ancient medicine. And I've talked to Rob before. I trained some in China, where these are complementary. You go to the hospital, there's a traditional medicine, there's modern there. So initially, people they try the traditional medicine, even they're not 100% data proven, but through the years of centuries of use. And then once they do not like modern medicine, maybe for just even palliative thing, then they go back to natural medicine. Hopefully, both sides of this in future comes together and have a complementary thing for the patient. It's all about patient, how to feel better and then make a, recover from this chronic COVID or any other disease as well.
Yeah. Everything has its place. Sometimes when you're in an acute medical crisis, you need pharmaceuticals and nothing else is going to help you, right? But with a lot of these chronic conditions, especially if there aren't pharmaceutical drugs that can help, trying the more traditional route, as long as the products are safe, right? As long as there's a really good safety margin on them, then what's the downside to it? Is kind of my attitude about it. And it's not like I'm trying to say this is better than any pharmaceutical therapy that's out there. It's here's something to try because there's not really pharmaceutical therapies, or the one therapy that's out there, which is triple anticoagulant therapy, does have some safety concerns at the end of the day.
Well, I definitely learned a lot and enjoy your conversation.
How can our listeners find you?
The best place to find me is if you go to keithcellisphd.com. Everything's there. So there's a link to my Substack. If you want to check out the science, the Substack pieces are all kind of longer form written content that have references to the scientific literature, all that good stuff. There's links to all my social media there, and there's a link for the product as well. The product's called CircuGuard. There's a link there if you're interested in go checking it out. The sales page tells you all about how it was designed and what it does and why it should work. Because I'm a big believer in kind of putting all the information out there and letting people learn about it and make their own decision about whether they want to try it or not.
Well, thank you for your independent thinking and for coming on the show. And we look forward to hear feedback from our listeners.
Great. Thanks for having me, guys. I really enjoyed it.
Thank you. Enjoyed it. A wonderful evening.